Hi, everyone. It's Dr. Kevin Zorn, founder director of BPH Canada. It is the beginning of summer here, and kind of reflectively looking back at this past year's EAU as a teaching point of where are we going as a society in urology to deal with these larger prostates we're all encountering. Will we all learn how to do hole up and thule up and other types of laser enucleation? Are there other newer technologies and the adoption of robotics that are going to be able to help us to deal with these larger prostates in a more reasonable amount of time, less educational fellowship training needed, what have you. So this is one of the take-home messages from this past year's EAU in Madrid, which highlighted the initial data from the Water 3 trial, which there was a randomization of aquablation and HOLEP-THULEP laser enucleation of these large prostates. And that was defined as a prostate between 80 and 180. So a little different than the Water 2, where it was 80 to 150. This included even larger prostates up to 180 cc's. And we're going to present a little bit on the 3-month data. What did we learn? Durability, IPSS improvements, sexual and urinary function and continence outcomes. Here's my disclosures. I guess one of my disclosures, I learned how to do HOLEP as a medical student back as a student in the early years of Dr. El-Halali at McGill. So for these patients, it's important to understand that aquablation has been well established since the initial series of the Water 1, Water 2 trials in 2016-17. I think everyone's very familiar with. If we look a little closer at the Water 2, it was 101 men, and they were treated by a large number of surgeons, about 16 different sites. So a lot of novice early users. Everyone had less than 10 cases performed. This is the foundation of its approval in AUA and EAU guidelines, including Canadian as well. So, most of these treatments were less than 2 treatments, and to which the primary endpoints, that were being studied and we're going to be looking at are that 3-month data. So if we look back at that initial Water 2 trial, those initial studies, we forget to look at, these were novice surgeons. There was no cautery, very little. And we used this thing called a continuous traction device, a balloon with a certain number of newtons that were added to compress the prostate as hemostasis. And so I think that was what was some of the concerns of bleeding and transfusion rates in that initial series. Certainly we've evolved, kind of like the iPhone. It's hard to compare iPhone 1 and 2 to the latest 15 version. So you can see here on that data, at 3 months, marked improvements in the IPSS and the quality of life. And again, these are beginner surgeons. Not many have done that many aquablations. This is 2017. And I think when we look now 5 years out at that initial beginner user durability at 5 years, again, early on first experiences, the retreatment needing surgical BPH reintervention within 5 years, 3%, and going back on medications only 6%. So that's very different, very drastic than some of the stuff that we're seeing for some of the missed technologies. And when we now bring in the comparison of what's being presented from the Water 3 aquablation series, and that's on the far right here, you can see that the comparator, they're very similar in terms of their volume of prostate, the PSA, middle lobe, the number, men in retention. So it's not a different cohort. Very similar in terms of what we were seeing from 2017 to this, more advanced user group in the Water 3 trial. And if we compare, the OR time, so in this later, advanced technique where we are using cautery, everyone's doing 2 passes or maybe more, the OR time was only added, maybe 21 more minutes of operative time from door in, door out. And the amount of tissue, obviously there was more anterior tissue being resected. And if you look at the transfusion rate, it dropped to 0. I mean, I can't say it's 0, but it's definitely less than 0.4%. Dr. Elterman published on a huge series of more contemporary users using cautery. It's no longer in what we saw initially in Water 1, Water 2. So that's drastically changed. And with the incontinence, it's not always determined or explained that well, but I think with a laser enucleation, there is a transient incontinence that's experienced. So looking at those who've had aquablation from water, 2 and water 3, look at that. At the 1 month and 3 months, we're looking at 1 and 0% incontinence, stress incontinence. So that I think is a reflection of the mechanical. There's no, force or fulcrum effect on the sphincter. The morcellator, there is none. The scope size and sheath size and the duration of the treatment for the aquablation component is usually less than 15 minutes. So I think the time on the table, and the speed and the no heat all have some factor with that as well. Looking at integrated ejaculation preservation, so we're using more cautery with the Water 3 latest series. We would think there'd be less success with preservation of ejaculation, but we saw the opposite. We went up from 81 to 85% in these larger prostates, and no erectile dysfunction, as would be expected. And if you compare this to the LEP group, those doing the laser, the HOLEP and THULEP, who've all done over 1,000 to 2,000, so you can see the OR time, 61 minutes. That I don't think is reproducible amongst all HOLEPers or THULEPers. And the transfusion rate was, non-significant, but it wasn't zero. And the incontinence defined as 1 pad or more at 3 months, 3 months, is 9.1%. And compared to other series looking at the 1 month outcomes, which weren't reported, have been reported anywhere from 15 to somewhere up to 45%, requiring physiotherapy or other types of maneuvers. And the antegrade ejaculation, only 23%. When we're looking at the IPSS improvements or reductions, comparable. There was no difference if you did an aqua or a laser enucleation in terms of reducing IPSS outcomes as the primary endpoint at 3 months. So significantly stable difference in outcomes, whether you did an aqua or you did a laser enucleation. So there's no superiority by having more tissue removed with the laser technique. When looking at what we're doing with aquablation, there's sort of compartmentalization. They were able to address middle lobe separately, mid prostate, and then the apical region of the butterfly cut. So each section of the prostate can be addressed differently depending on the age, personalization effect. When you do enucleation, you must engage, usually in a uniform fashion, in the surgical plane, just adjacent to the vera montanum, and that's just the way you have to do it. There's only one way to do HOLEP, and that's why the outcomes are so reproducible. But, as we're going to be discussing here, is the more and more of our patients have heard about this, and we kind of threw under the rug that, oh, you're 7 years old. Ejaculation is not really important. You don't want to have kids, but it's part of the orgasmic, satisfaction to most men. And we've actually ourselves and a few others have studied the importance of what in surveys patients feel are important. And over 70% of men over the age of 65 felt that ejaculation was very important. They like to preserve it if possible. So again, as the urology community, we're seeing more and more of a demand, a wish list that patients see value in ejaculation, not just for fertility, but in terms of male satisfaction, the fulfillment of the orgasm, and the idea of the butterfly cut has really changed how we viewed ejaculation, which was once thought to be part of the bladder neck and what have you. So it's no longer the bladder neck, it's the pericollicular tissue, it's the ejaculatory ducts, and its preservation. So it's not just preservation of the duct that we see here, but the tubes that go beneath that are kind of the 1 centimeter lateral to midline, 1 centimeter behind the vero. That's where the duct system will plunge down and engage toward the seminal vessels. So as long as you don't injure that ductal system and part of the ejaculatory anatomy, which is another separate talk I can give, that talks about what our understanding is of the key elements needed to preserve for ejaculation. But the magic is really here in the butterfly cut, and to which other lasers are trying to mimic to get the same outcome. So there you go. You were able to preserve under visual, under ultrasound, real time. You can make adjustments and not injure that. And in terms of tissue removal, what was the difference in that Aqua 3 versus Water 3 study? If you compared the Aquablation group, there was a 51% amount of tissue removed, whereas the laser enucleation is a lot more, I guess, anterior, and the apical tissue also being removed, which is about 76% reduction. So relative to his TERP, I mean, that's just a phenomenal number across the board. And I think you can remove more by doing the enucleation, but it comes at a cost. The fulcrum at the sphincter and some of the things we've talked about already, the incontinence and ejaculatory function. So the question, what we're seeing here is with aquablation, there is a deliberate and purposeful preservation, especially in the apical region, that's going to lead to those functional safety hazards or safety functions to the patient, which once lost, at least with ejaculation, tend to be permanent. So, if we compare that to how much tissue is removed in the water too, about 41%. So we're removing about 10% more than our initial experience. Something has to do with the TERP loop, perhaps a more aggressive second or third pass that we were not doing prior. So in the study, they actually commented, the prostate volume reduction. They report on that, not the PSA. And unfortunately, there's really no standardization. So if I were to measure this gentleman, who's one of our aquablations at 1 month, which I tend to do, and show the patient what was done, it's kind of, demystifies men are visual creatures. We want to see what got done. Here you go. Here's your hole within your prostate. How is the standardized approach to measuring volume in a hollow, spherical structure? And that's not something that is uniform and has to be taken into account. So I think getting the PSA nadir at 3 months would be something that would be more reflective. And this has been published in the whole up literature. So, if you look at the Water 2 study, the reduction of the PSA did correlate well with the volume reduction. So, I hope to see in the future Water 3 publications at 6, 12 months, the PSA should be something that's included in the paper. So in conclusion, I guess, what did we learn from the Water 3 that's going to give us a glimpse toward the future? When comparing these expert high volume, performed on collectively more than 2,000 cases in Germany to just proficient, having done at least 30 aquablations and looking at the 3 month data, robotic aquablation has comparable efficacy in the IPSS. You can democratize, no matter what the size of the volume of the prostate, you can likely do this case with low stress, low anxiety in under about an hour. The efficacy in IPSS, as we saw, and the PVRs comparable, and the bleeding events no longer an issue and comparable to the laser technique. And with regards to the superiority element, so we've seen the superiority of aquablation to TERP for the 50 to 80 gram prostates. Well, now it's got a superior element of safety with regards to stress incontinence, wearing pads, at least one or more, and ejaculatory function, which I think everyone has heard quite clearly. So there's clearly a value of having this robotic mixture that's merged and married in with ultrasound and predictability and able to have this sort of access, maybe their limitation globally, since right now only about 20 of the 196 countries in this planet have access to the Aquablation robotic platform. So looking ahead, I think, what we would want to see in 5 years from now, this Water 3 data, what will those retreatment rates be for both, laser and for aquablation? But it's aquablation version 2.0 because now there's cautery, there's a lot more experience, and certainly our understanding is, we're still learning more and more. But this platform that's even being taken into Water 4 trial now, looking at prostate cancer, just imagine the day when we're able to predict. So with PSMA PET, as other types of imaging, that's going to help us localize much more clearly where the lesions are. So if you can ablate them endoscopically and not just focal ablation, but focal resection, like it's gone, I think this will be quite impressive. So, forthcoming, if we look at the 5 year data, we're going to see better standardization. We should see better, perhaps other details of the cost. So cost of incontinence, and most important, people don't even talk about it, the cost of the surgeon. So in BPH technology, myself having done HOLUP and others that have done these other types of, single port surgeries, there's a stress of the body, there's anxiety, there's different musculoskeletal stress factors that are at play for these longer surgeries. And what is that cost and stress, anxiety to a surgeon? And what's that reproducibility? And to take a technology like aquablation as an example that democratizes within 5 to 10 cases, any person on this planet with a foot, a hand, and some experience with the loop are able to tackle larger prostates that normally would be relegated and sending the patient off elsewhere. So, it's nice to see such technologies. And I guess looking forward, kind of as an expert KOL in BPH, as stents come in, as other myths come in, for the men who are looking for a de-obstructive procedure, looking to get, the maximal output and preserve, the incontinence, preserve elements of the sexual function. I think the aquablation will continue to gain strength, and kind of like Apple computer or your iPhone, it will serve as a platform to which other apps will come on. Imagine the day where we can see vascularity, we're going to see tissue elastography. We can predict better who will treat, with certain types of stents or have you. I think that it will be our next, seminal moment in BPH therapies, as well as tissue regenerative technologies. Is it PRP? Is it other types of hemostatic agents that's going to help us stop bleeding and perhaps even reepithelialize the defect we've created in a rapid time, and make the surgery and the whole experience, not just surgery, but the recovery faster. So final thoughts, I think, the Water 3 adds more information of the growing evidence that, challenging the HOLEP as being the one and only, and despite it approaching its 40th anniversary, 1998, Dr. Gilling launched it to the world, and Todd onward, it still represents under 10% of urologists doing this technology, despite all of its merits. Is it because of the challenge, the reimbursement, what have you, the patient's loss of ejaculation and the recovery of incontinence? So those elements of incontinence and sexual function are not to be neglected. I think that's another element why that has not taken off in terms of mass adoptability. It tends to be a fellowship training that's needed. And so the aquablation will be, I think, a continued growing technology that will be brought into many other people's practice beyond their fellowship, deep into their practices as an early add-on, and the benefit to the patient seem quite clear. So, that's about it. And I think BPH area will continue to grow, especially with our aging population, our declining or stable workforce, and the elements of stress in our ability to treat as many patients as we can with a fixed amount of time. So, robotics, AI, all this are the hot topics, and I think aquablation seems to be meeting some of those points in our endeavor of challenging larger prostates. So with that, I appreciate your attention. Thank you, and come visit the rest of the library to learn more about other aspects of urological care. Have a great day.